Vitiligo is seeing another exciting moment in therapeutic development as well, in part because we're really trying to push JAK inhibitors beyond the topical route for this disease. And so, of course, topical ruxolitinib has been a really important game-changing medication for this disease because we really haven't had targeted treatments for repigmentation. But the question has always been, for somebody that has higher body surface areas, or for somebody that just can't practically apply a cream every single day for multiple years, given the fact that there are slow results when it comes to thinking about treatment and repigmentation, could an oral molecule do the heavy lifting? And this is where the upadacitinib data comes in. Some of the longer-term data suggest indeed some of the patterns we've learned about JAK inhibition appear to be true in the oral realm. You sort of start out daily dosing, keep going, and over time, it takes several months, and now looking at a year, you can really drive high levels of repigmentation, not only in the facial region, but I think probably what's going to be a major benefit of these oral molecules, some of these other harder to repigment areas around the body too. And so really, you're hitting a lot of areas at once, whereas with a topical therapy, for somebody that may have more than, let's say 5% body surface area, it may prove to be impractical, especially if you're thinking about a twice daily application. So I'm really excited for therapeutic development in this space. And given that we have so much safety data with upadacitinib across a lot of different dermatologic and non-dermatologic indications, I would imagine that this isn't going to be a major question that people have because we've already thought about safety in so many different ways. And so there shouldn't be too much of a surprise here. It's kind of nice to be focusing mainly on efficacy without necessarily being super concerned about the safety part, just because we have so much data already. Yeah, so I mean, I can say that number one, I was happy to be a co-author on this study, and let me break it down for you really easily. Tapinarof is our aryl hydrocarbon receptor modulator that's in a 1% topical formulation, approved for psoriasis, under study for atopic dermatitis, and thus far from what we've seen of the actual primary endpoints and top line data, really checking the box on all of those in a moderate to severe population in which it was studied. So this particular analysis to which you're referring was really talking about individuals who identify perhaps as having darker toned skin, non-white racial groups, exactly what was being seen in their skin too. And I know that some of these are social groupings and not truly necessarily biologically relevant groups, but I think they do provide important, let's say, groupings when thinking about diversity as far as patients go. And when it comes to the treatment of tapinarof, the results were nearly identical across all the different sociodemographic variables that were analyzed, and even light and dark skin tone, suggesting that what we have come to know from other therapies definitely appears to be true for tapinarof. But the important wrinkle is this was one of the most diverse trials we've had in recent mind, with an extraordinarily high percentage of individuals identifying as diverse skin types, whether you use race, ethnicity, or skin tone into account. And so I think that it's important to note that this is probably some of the more powered data we have based on just the simple count of patients. And it formally tells us what we've come to know, that in general, oftentimes our scores at baseline or end of treatment can vary based on individuals' perception of erythema, hyper and hypopigmentation. But with the right investigators taking a look at these data, you can see very similar results across the board. So exciting stuff when it comes to tapinarof cream. Yeah, so lutikizumab is a medication that really sort of goes maybe a different route than we've used to seeing for HS. So it's really taking a look at the IL-1 specific pathway. And in particular, this is an antagonist for IL-1 alpha and IL-1 beta. IL-1 being an important and pleiotropically acting inflammatory cytokine that we think about in not only acute, but also chronic inflammation. HS has been a tough disease to treat because it's been really hard to nail down which specific pathway is going to be the key one when it comes to thinking about drug treatment and drug development. And so this particular study to which you're referring, a phase 2 study, took an aggressive approach, and one that I applaud, and actually looked at individuals who had failed anti-TNF therapy. So ones that had not necessarily had a great response or lost response to our first approved option when it comes to thinking about TNF alpha inhibition. And what they found was that indeed there was higher response rates observed, looking at the variety of endpoints, pain reduction as well. And when we think about sort of what these endpoints are, typically we're looking at reduction in nodules and abscesses and some of those acute signs without really worsening of actual chronic signs in terms of tracts. And so this is exciting because any drug that can achieve superiority over placebo in the HS world is exciting. It's really hard to do given how many trials just haven't successfully been able to get there because of a variety of factors: unpredictable placebo rates, a very waxing and waning disease, questions about whether or not we're looking at the right endpoint at the right time. So it's very intriguing to think about a drug that maybe is acting at a very key core early and underlying cytokine across a lot of the inflammation and disease. And I'm particularly interested, once this moves on to phase 3, what this potentially might look like.